Merci à Georges et à ses collègues de m'avoir invité à parler aujourd'hui de ma recherche. Mon français, c'est pas assez bon de faire une présentation de 60 ou 90 minutes. Alors, je remercie beaucoup la traductrice pour son aide aujourd'hui. Alors, je vais continuer en anglais maintenant. So I'm here, have the real privilege of being here today to talk to you a little bit about a journey that I've gone through and had the fortune of going through that with George and some of the other colleagues that you all know through this group, and trying to translate some of the work that we do in the research lab on parent-child attachment and making it accessible in clinical practice to those who are working with families directly. And so over the course of the next 90 minutes, I will really, do an overview of parent-child attachment and specifically disrupted parenting behaviors. And those are the types of parenting behaviors that we see most often when children develop disorganized attachment. So I'm sure you've heard a lot about attachment throughout these talks. So I'll just really briefly do an overview there. And I'll talk a little about the AMBIANCE-brief project, which is a project, the AMBIANCE is a measurement tool where we try to code maternal behaviors that we consider to be disruptive or problematic in terms of children's disorganized attachment. And what we did is try to take that measure and make it feasible for use in a clinical setting. So I'll sort of talk you through our journey in that process and then go through some clinical applications of how we use this tool in treatment settings. So one of my favorite quotes in attachment from one of the sort of pioneers of attachment is that the attachment is this deep, abiding confidence a baby has in the availability and the responsiveness of a caregiver. So I think that's sort of a foundational and critical component of the child's livelihood and optimizing child development is really that they know that the caregiver is there for them, can be there for them consistently, and is good and responsive at responding to any cues and signals that they have. So they really have a deep sense of knowing that that caregiver will be responsive when they are in need. So it's believed that we all have an attachment behavioral system. So this system, when it's under threat, it really inhibits some of the other systems we have. So when our attachment system is activated because we feel it's under threat, for example, our caregiver is a little too far away from us, or we can't see our caregiver, what we find is that it inhibits other systems like our exploration system. So when kids can't locate their caregiver, they get anxious and they stop exploring their environment, and they sort of can't really regulate their behavior until that caregiver comes back. So the caregiver can play a really critical role in helping regulate the child's stress. So when they're close to them, they can give physical contact and comfort. And they can also be really responsive to children when they signal cues, when they vocalize, when they tell the caregiver that they're in need, either in a nonverbal way or in a verbal way. So the caregiver plays this really critical role in regulating the child's stress response. And this can be really foundational for the child's development because that's going to regulate how they respond to fight stress in the future. So we have what we call the fight or flight stress response system. And that's something that if the caregiver can consistently help the child regulate and work through, we know that when that's activated in the future, the child will actually develop some coping strategies to be able to get through some of those adverse experiences or stressful experiences. So what we've all probably heard a lot about is secure attachment. So secure attachment develops when the caregiver can be used as a secure base for the child. So the child's very aware that when they need that caregiver, they can go to that caregiver and really get what they want. So they feel safe in the comfort and knowing that the caregiver will respond to their signals and bids. And also, as a result, they're okay going out and exploring their environment and learning about the world around them. So they see their caregiver as a safe haven who can really provide that comfort and safety and can really help with that co-regulation process when they really need help in managing their upset or their distress. And what lots and lots of research has shown is that when children have secure attachment, they typically have more adaptive or more optimal functioning throughout the lifespan. So in childhood, in adolescence, and even in adulthood. And it crosses over multiple aspects of development. So they're more likely to they have better language skills. They might be more, they have stronger academic skills. They're also better, they have better interactions with their peers. They're more likely to, they're less likely to develop behavioral problems. So secure attachment is what we want all children to be if we could choose. Unfortunately, only about 50 to 55% of kids have secure attachment. And, you know, there's been a big movement to trying to increase that through a lot of intervention programs, which I'll talk about really briefly in a moment. But there's two types of insecure attachment. These are still considered organized attachment strategies, but in children who have insecure avoidant attachment, what we see when we look at their behavior in the strain situation paradigm, which is where we often assess their attachment classification, we see that they have very low distress, so they don't seem particularly bothered. The caregiver goes in and out of the room. They seem to be okay with that. They don't really check in with the caregiver very often, so their contact seeking is very low. They're not very likely to go to the caregiver. What we know physiologically is that they're stressed out by the paradigm, but that doesn't lead to them going and seeking any contact or comfort from the caregiver. There's also children who have insecure resistant attachment, and children with insecure resistant attachment tend to be quite distressed by the paradigm. So they often struggle to manage their distress, and they have high contact seeking. So they're really clingy essentially with the caregiver, and it takes a lot of work, and sometimes the caregivers are ineffective altogether at really getting children back into the toys and exploring their environment again. So these three attachment classifications, typically we think of, if we can promote sensitive responsive parenting, we can promote secure attachment. So it'll be less likely that children will develop insecure or resistant or insecure avoidant attachment. So the construct of sensitive parenting is really foundational to attachment research and to a lot of the intervention programs that are out there right now. So sensitive is about being warm and nurturing and obviously really predictable. So when the child cues, the caregiver responds. Really trying to being comfortable with both positive and negative emotions. So even when negative emotions are displayed, the caregivers can be sensitive in providing the contact and comfort that the child needs to help regulate that negative or distressful emotion. And then responsive behavior is the piece, what's about contingency. So it's about how the caregiver responds to the child's impulses and signals. And do they respond to them promptly, consistently? And you can think of it as a game of tennis. So when the child serves up the ball or serves a cue to the other side of the net to the caregiver, does the caregiver perceive that ball? And does she hit the ball back to the child in the direction that they can then engage in what we call serve and return interactions? So these back and forth interactions that are contingent and very responsive towards the child's needs. So I'm going to just show you a small little clip, and what you'll see here is what I'm trying to illustrate with serve and return interactions. The baby will touch the mother's face really gently, and what you'll see is the baby turns towards the mother turns back towards the baby, and they just have this lovely mirroring of affect. So just a perfect illustration of how you can do a serve and return, or how we'd like to see a serve and return interaction. So we know that these serve and return interactions are really a critical ingredient to children's development. So this is an example here where we looked at a variety of studies and pulled them together into one big study. And we really wanted to see, is it about that contingency, so the serve and return piece, that's really important? Or is it just enough for the caregiver to give lots of kisses and hugs and be there from a warmth standpoint or a loving standpoint? Or do we need to see those serve and return interactions? So it turns out that for children's language development, both of these really matter. So both of these play a role in children's language development. So as sensitive responsiveness increases and as warmth increases, children's language skills get stronger. But what you see here is just the difference in showing that that sensitive responsiveness, that back and forth, those conversational turns that caregivers can have with children are a really critical ingredient. So it's something we want to optimize as much as possible in interventions. So the research has pretty consistently shown that when sensitive caregiving is high, children are more likely to develop secure attachment. So that's fantastic. And that finding has really spurred a variety of different intervention programs that are really focused on promoting sensitive caregiving, increasing caregivers' capacity to sort of think about what it's like to be the child, so increase their reflective functioning, or they're able to get into the mind of the child and understand their wants and needs. So I just put a few great interventions up here, some of them you're probably very familiar with and are led by Georgie's colleagues. So, you know, there's great research to show that these work. So I think that's really positive. As I mentioned at the start, there are a lot of children who have secure attachment, which is fantastic. So 52% of children have secure attachment, and then a smaller percentage have avoidant attachment or insecure attachment. But what you'll see here is that about 24% of children globally will have disorganized attachment. And so that's like a classification of attachment that's gotten a lot of attention, certainly more recently, because we know that disorganized attachment is associated with a variety of outcomes for children that are not very positive, and it can lead them down a trajectory that is associated with behavioral problems and different psychopathologies throughout the lifespan. So that's what I'm going to focus the rest of my time on today, is really trying to understand what predicts disorganized attachment and the measurement that we've used for that and how we've adapted it for clinical practice. So disorganized attachment is often called fright without solution. So kids are seem to both need their caregiver, but also fear their caregiver. So we often see behaviors from them where they will approach the caregiver and then back away. So they seem inhibited in some way in going to the caregiver for contact. So there's some fear or apprehension in their behavior. And they don't seem to be able to go to the caregiver at all when they're really in distress. So when distressed, they almost collapse because they can't go to that caregiver, but they really need help. So essentially they turn inward and often freeze still or fall to the ground and really can't take any action to manage their distress. So here I'll show you, it's black and white, but I'll show you an example of a child who's showing disorganized attachment. So in this case, he's sitting here with a stranger, so someone that he's just recently met, and the mother will come into the room and go towards the chair. And what you'll see is the child will look for help, but not be able to go to his mom for help. And unfortunately will fall on the ground and just basically fall prone to the ground and not be able to go to anybody to manage his distress. And he essentially gives up in the end.
Hi. Oh, David.
So this is a child who can't go to this caregiver for help or comfort, and rather, sort of collapses to the floor. And over time, you can imagine the strain that this would have in him in terms of regulating his behavior outside of this context, or if he has no one to go to help him learn any coping strategies to get through difficult times. You can see why this might be difficult throughout the lifespan. So we know that in the prevalence of disorganized attachment is, as I mentioned, around 20 to 25% in middle class samples, but tends to get higher as the risk in the sample gets higher. So we see that in adolescent mothers, the risk for disorganized attachment is a little bit higher. And I've given some examples of moms with who are struggling with different, or dads who are struggling with different psychopathologies like drug and alcohol abuse. And then there's the pretty consistent findings showing that mothers who perpetrate maltreatment or parents who perpetrate maltreatment are more likely to have children with disorganized attachment. And I'll pick up that point again just in 1 second. But just to say that there's some pretty good research to suggest that there's quite a lot of clinical concern about children who have disorganized attachment. So their stress reactivity is very high. And they also show a variety of different problematic outcomes in terms of struggling to interact with their peers, relational aggression, having problems with suicidality, borderline symptoms, and the list actually goes on and on. But and I suppose one of the strengths in some of the work in attachment is that children have been followed for a really long period of time. So in some cohorts, 30 years. So able to track children from 30 years ago who had disorganized attachment and follow them over time, and they are demonstrating quite a significant amount of struggle in terms of their sort of daily living. So as I mentioned earlier, sensitive responsiveness parenting is strongly related to secure attachment, but it's actually not very strongly related to disorganized attachment. So this has really pushed the field to try to understand what's happening in terms of antecedents, or what comes before disorganized attachment, or what's basically predicting the development of disorganized attachment in children, because it doesn't appear to be sensitive or insensitive caregiving. So there's a really lovely paper by Per Grankvist and al., and this is open access if you want to grab it. And one of the things that they really emphasize in this paper is that disorganized attachment, of course, is really common among children who have been maltreated, but there are a substantial portion of children who of maltreated children who don't show disorganized attachment, and many children have disorganized attachment but don't have a history of maltreatment. So while we do see an increased risk of disorganized attachment in maltreatment settings, it's also happening outside of child maltreatment. And so that makes us really have to think about the various pathways that might exist towards disorganized attachment. So like similar pathways have been proposed in and around parental behavior. So Mary Main and Eric Hesse proposed in 1990 that infants who display some of these more disorganized behaviors do so because the caregiver's behavior is frightening. So they're frightened. They're either frightened of the child, or it's aggressive and frightening to the child. And then Caroline Ruth and her colleagues followed up with a bit of an extension of that theoretical idea and said it's obviously that they're frightened or frightened of the caregiver. The caregiver is frightened or frightening, but the caregiver also isn't providing enough to the child to effectively help them manage their regulation or their arousal when fear is in the environment, like it is when we test their attachment classification. So from this theoretical hypothesis, Caroline Ruth and her colleagues came out with a coding system in a similar vein to how we code sensitive caregiving. They're developed a coding paradigm to code what they call atypical, or more recently called disrupted affective communication errors, disrupted behaviors that the caregiver is displaying, to see if these would be linked to disorganized attachment. So they developed the AMBIANCE measure, which is the atypical maternal behavior instrument for assessment and classification. When this measure was originally developed in around 1990, all the focus was on moms in research at that time. So we have maternal behavior here, but this has obviously been adapted, and we've evolved as attachment researchers and studied all caregivers. But I suppose it worked with the acronym here to have maternal in there, but we do study both moms and dads. So what I'd like to do is give you some real concrete examples from this coding system. This was developed for research for intensive coding of maternal behavior. So I'm going to start with giving some overview of that, and then explain how we've shrunk it down and tried to make it more applicable for clinicians. So here are some examples of the AMBIANCE behaviors. It's broken down into 5 different dimensions. So over 5 dimensions, we will code a variety of different caregiving behaviors. And so they're grouped in these 5 ways. So we're calling them 5 dimensions, but they're really just sort of 5 groupings of behaviors that we tend to cluster together. So affective communication errors are when the caregiver is really inappropriate in terms of how she responds to the infant. So she laughs at the infant distress, or when the child is upset, like the child we just saw, there's absolutely no response to the child. So the child is cueing that they need something, and the caregiver's affect or communication is a true error in terms of what the child needs. So they don't effectively return that serve that the child is giving up to the caregiver. And what I'll show you here is just an example of how a caregiver might laugh at the child's distress when they're upset. So this is a child who's clearly very upset, and there's a period of time where there's no effort to soothe the child or provide any help towards managing their distress and their dysregulation. And then there's laughter. So this is a real clear, mismatch in affect. The child is very distressed. There's laughter at that child's distress, and that can really minimize the child's experience, and also make it less likely that they'll go to that caregiver in the future when they need help. The other dimension of behavior that we often examine is something called role boundary confusion. So this is a dimension of behavior where the infant is really putting the child in the position of being the parent. So they're demanding affection from the child. They're asking the child to take care of them. Their needs become the priority. So there's a really clear need to have the infant focus on the mom instead of the mom focus on the infant. And this takes on particular salience when the child is upset, because that's a time when they really need the caregiver to be that stronger, wiser self and help the child manage through a difficult situation. But if that's occurring and the child is upset and the caregiver is saying, focus on me, what about my needs? You can see how that can be very difficult for the child. And again, make it less likely that they could go to them in the future. So here's just an example of that. So make mommy feel better, help me. So that's an example of how you're switching the roles there. And what we've shown over time is that, interestingly, some of the cases where we've coded children when they're a year old and we've followed them up 20 years later, one of the things they'll say to us is, I couldn't move out of the house because I had to take care of my mom, or my mom, has tried to commit suicide a few times, so I'm always afraid to leave. And there's a real sense that they do eventually start to be the caregivers in the relationship. The children become the caregivers and then have to take care of the parent, essentially. So that can be a very difficult position to put kids in. This is just another example of, the moms just come back in the room, and rather than play with the child or engage with what the child is, she's going to ask repeatedly for affection from the infant. So eventually mom will go to him. Now we've all asked for hugs before, so that happens from time to time. But when children are in the strained situation, what's happening in that case is that children are they really need their caregiver because they've been left in the room alone or they've been left with the stranger. So we really want the caregiver to focus on the child rather than ask the child to focus on the caregiver. Another dimension is fearful or disorientation, and this often mirrors some of the behaviors that we see in terms of the infants in the strain situation, but these are the moms showing these behaviors. So they seem very apprehensive or fearful in interaction with the child. So whenever they're around the child, their shoulders are up, they're apprehensive. Sometimes we see moms will zone out or show dissociative behavior where they will almost appear like they've sort of disconnected to the environment a little bit, or their affect gets really flat and it looks like they're really not very present or struggling with something maybe from a mental health perspective, and they've sort of disconnected from the interaction that would be going on with the child. So oftentimes when we look back and look to see, some of the histories of moms who show really high fearful or disoriented behavior, we sometimes see trauma histories. So they might be triggered for some reason during the strain situation, or just really struggling with some of the very difficult life experiences that they've had. The other dimension is intrusive or negativity. So when caregivers are aggressive towards the infants, they might push them into seating positions or mock them. So like they might sort of do some mild embarrassment of them or criticize them. They can also just do some really rough handling of the infant. So that it's almost too aggressive for what we would expect during an interaction, or they use very sharp or angry voices with the child, or are really controlling around some of the objects that the child might be playing with. So if a child wants a toy, the caregiver pulls it from them or tosses it up in the air a few times and doesn't give it to them. So they kind of tease or mock them. So here's an example of a caregiver who's just treating the child as though, they're inanimate or behaving a little bit too aggressively with the child in terms of their behavior. You'll see they'll come into the room and they pick up the child from the wrist and lift them up. So that is obviously, and some of you have unfortunately maybe seen some more rough handling than that, but in the context of the strain situation and or in an interaction, we wouldn't normally see that. And sometimes these are the things we would code in the context of the interaction, just sort of that rough handling of the child. This is an example of mocking where the child is going to say a cue and obviously is struggling a little bit here. And the caregiver, instead of attending to that cue, will actually make fun of it. So just sort of mocking of the child's cue. And you can see the child's face actually stops and is a little uncertain how to navigate this. So I think that's also notable in that clip. Withdrawal is the last dimension, and this is just when the caregiver really is not available to provide any support or scaffolding for the infant. So we often see withdrawal behaviors like not greeting the child, not talking to the child, stepping over the child, to go and sit in the corner, go and sit in their chair. So we really are seeing a lot of physical distancing, as well as sometimes verbal distancing, saying things like, I won't pick you up right now, or using the toys as a substitute for the self. So the child might approach the caregiver and they turn them back over to the toys. And I'll just give you two examples that would sort of capture this dimension a little bit. So this child's gonna stand up, put his arms very clearly out. That's a very clear signal. And rather than invite the child in, the caregiver sort of redirects the child back towards the toys. So I'm going to pause it here because this is a great example of, the child's arms are up. That's always a sign like, pick me up, I'd like some contact. And the caregiver's response here, rather than, wanting to take that and help the child, is to redirect them back to the toys. So oftentimes, in this dimension, there's sometimes like a hot potato quality to the interaction where the caregiver might pick the child up, but they put them down right away or put them down before the child's ready. So hopefully that translates that hot potato quality. And then sometimes we just see no interaction. So the child is, signaling and cueing and they're distracted. And something we've been seeing a lot more lately is that they're distracted by their phones. So the child's giving lots of gorgeous cues and coos and signals here. So just, lots of cues and signals and no response to that, or the child's got to signal quite a lot louder to get a response. So when we do coding for ambiance in the research context, it takes about 100 hours to become trained and reliable in the use of the measure. So that's obviously lots of time, weeks and weeks of time. And what we do is when we're coding, say, a 5-minute interaction, it takes us about 45 minutes to 60 minutes to do that, because there's about 150 behavioral codes on the ambiance measure. I showed you a few in those clips, but there's about 150. So that's a lot to retain and code. And we do a very, very detailed narrative, 2 or 3 pages, where we describe everything's going on. So that can take a lot of time in the coding as well. We have rating scales for each of those dimensions. So we give scores from 1 to 7 for each of those 5 dimensions that I mentioned. Then you give an overall level of disrupted communication. So is this dyad high in terms of their disrupted caregiving behavior or low in their disrupted caregiving behavior? We also classify individuals as being disrupted or not, and that's a really common thing to do in attachment research, where you indicate if people have disorganized attachment or not. Here you're indicating if the caregiver has disrupted caregiving or not. So again, it takes about 60 minutes to code, about 5 to 10 minutes of interaction. So in the research context, where we have the luxury of time, this is very manageable and strongly recommended that we do that kind of detailed coding in the research world. And what we find is that the ambiance is a very strong predictor of disorganized attachment. So the ambiance, or I've been calling them disrupted caregiving behaviors, which is all the items embedded in the ambiance measure, are strongly related with disorganized attachment. So we do know that that association is there. And the research suggests that when moms show disrupted or these ambiance behaviors, they're almost 4 times more likely to have a child with disorganized attachment. And then when you actually compare in an independent study how strongly predictive sensitivity is to disorganized attachment versus disrupted caregiving, what you can see here is there's a significant difference. So sensitive caregiving or insensitive caregiving is not a strong predictor of disorganized attachment. In this case, it's not at all a predictor of disorganized attachment, at least in the sample that was published in this study. But disrupted caregiving was a strong predictor of disorganized attachment. So we know that those disrupted caregiving behaviors are really a critical ingredient in disorganized attachment and helping us understand the development of disorganized attachment. So the ambiance and disruptive behavior has been coded in children from 4 months to 7 years of age. And there tends to be quite a lot of stability over time in terms of the display of these disruptive behaviors, meaning that if moms were showed disrupted caregiving behavior at 4 months, they were more likely to show it at 12 months and at 7 years. So this tends to be quite stable over time. And we also see that when we've followed families over time, sometimes 20 or 30 years, that when mothers were classified as having disorganized or disrupted attachment in that early childhood period, we're seeing that their children are struggling throughout childhood, adolescence, and even early adulthood. So in childhood, when the ambiance is I'll start over. When the ambiance is there's high disrupted behavior early in childhood, that we find that predicts disorganized attachment. It also predicts high increased infant and caregiver cortisol response. So it's having a physiological effect. And it's also having an effect on a variety of different behavioral outcomes. So not just behavioral problems like depression, anxiety, and aggression, but also an increased likelihood of substance use, some borderline personality features, and even suicidality in adolescence. So we are seeing over time that when these behaviors, these caregiving behaviors are present in the infancy period, it has an impact over time. So one of the things that we wanted to find out about is that can we, in interventions, if we are able to reduce these disrupted communication skills or disrupted caregiving behaviors, does that create change in children's disorganized attachment? So this is a study we published recently with a group in France who did the CAPED intervention. And basically in that intervention, they worked with families who were struggling for a variety of reasons, either from a low income, they had low income, were single parent families, and they randomized them into one of two conditions. The CAPED intervention, where they worked with families quite extensively over the first 12 or 18 months of life, and did a lot of video intervention feedback, worked with families in terms of providing support, and also drawing attention towards sensitive behaviors, but also trying to reduce these disrupted behaviors. And they compared the group that got the intervention to the group that didn't get the intervention, which is just care as usual, which was home visitors, doing a variety of things around, development. They had to attend to kids' development, not really anything that was focused on attachment. And what they found is that the group that got the intervention, the CAPED intervention, had those children were less likely to develop disorganized attachment. So we knew that the intervention was working in terms of reducing the risk of disorganized attachment. And what we then looked at was, is that because they're having reductions in disrupted behavior? And so what we did is we looked to see that is basically disrupted maternal behavior the sort of causal, or as close to we can as say, one of the causal factors in reducing the risk of disorganized attachment. So, and that is what we found. So what happened in this intervention is that those who got the CAPED intervention, that reduced their disrupted maternal behaviors, and that in turn reduced the risk of disorganized attachment. So this intervention study tells us that this is a disrupted maternal behavior is a key ingredient for reducing disorganized attachment. And fortunately, in a separate study that we weren't affiliated with, but tested a similar hypothesis in the attachment and biobehavioral catch-up by Mary Dozier and her colleagues, Heather Yarger was able to demonstrate that children in that intervention also had a reduction in disorganized attachment after taking the attachment and biobehavioral catch-up intervention. They were more likely, they had big reductions in parent withdrawal. So especially that fifth dimension that I talked about. So when withdrawal was substantially reduced, so then you would expect there'd be more engagement with the children. That was a key ingredient for change in terms of reducing disorganized attachment. So we know in interventions that when we reduce these disrupted behaviors, we will see a change, or we should see a change in children's disorganized attachment. So there are a lot of pros and cons, I think, of using the ambiance in a child welfare setting. And I had the fortune of chatting with several clinicians early on and thinking about how we might apply the ambiance to clinical practice. And so one of the things we did was sit down and say, well, what are the pros? Like, what's working for this measure that's rooted in attachment research? What works? So what they told me works was that it's going to identify some parenting behaviors that are often observed in child welfare settings, especially when you have visits between caregivers, supervised access visits, for example. It can provide really clear avenues for therapeutic intervention. So if you saw a caregiver that just really had a lot of withdrawal, wasn't interacting with the child, once you're cued in and can see that, you can then make an intervention plan to try to get the caregiver more actively engaged with the child. So, and the group I talked to said that they really liked that it was evidence-based. So the Ambiance measure has, 50, 60, 70 publications that have shown pretty repeatedly that it's a robust predictor of a lot of outcomes for children. So they liked that that was something they could have some confidence in. But there are a variety of cons, some of which you might have identified already or that I was hinting at. One is that it's just too extensive to train and spend the time learning this measure to be able to then integrate into clinical practice. So time is of the essence in clinical training and practice, and spending 100 hours, becoming reliable using this measure, and then an hour coding a 5-minute tape is just not feasible. Videotaping can also be really hard in a child welfare setting. One, because the equipment might not be there, but also because families are unwilling to be videotaped for a variety of reasons. And obviously, a lot of people who work in child welfare are on tight timelines and court processes, and there's really limited resources to be able to spend really getting to know an intensive measure like this. So there was really a community identified need to develop something that was more feasible for use in practice. And that's something that people would come to the trainings that were geared towards researchers and say, really like this measure, I just don't have time to learn all the details. Please do something about that. So, I really wanted to be able to provide that to clinicians. Being a clinician myself, I could know how valuable these tools are to use in practice. So we were wanting to sort of provide a measure that could provide opportunity for growth and focus in intervention, and potentially could offer a screening tool so that you could identify targets of intervention. So I will say that there is really, in attachment research broadly, a sort of a lack of validated tools has been really identified. A lack of validated tools for community practice has been identified as one of the major challenges facing the research to practice gap. So there wasn't really a lot for us to draw on in terms of how to create a measure that could be, that was sort of born in the research world and make it feasible for use in practice. So that was really our objective and our goal to do that. And we're going to go, and I'm going to talk you through the different steps that we went through to make that happen. So I'll skip past this slide because I'm not sure, I think I've already said this, but I think I was really guided by this principle, like knowing is not enough, we must apply. So, and willing is not enough, we must do. So in the research world, we learn, we know, we try to advance knowledge, but we need to then apply that knowledge. And it wasn't enough for me to want to do it. I had, I could want to do it, but I really had to go out and do it. And so that was really the push to make this project a reality. And I was so lucky because I got to do this project with a variety of my colleagues, many of whom you know, including George Tarabolsi and Chantal Sia, and have them to kind of give advice. And we worked with a variety of different collaborators to try to share knowledge and to try to move this project forward. So I'm super grateful for them for being my collaborators on this project. And so I'll talk you through what the project entailed and what we got to in the end in terms of a measure that is more feasible for use. So trying to follow it in a way that was empirically sound, the first step we took is to try to create a measure from the full ambiance and create a brief measure that we call the AMBIANCE-brief. And I'll talk you through how we went about that. The second step was to make sure that that was a valid measure. So it was like sound from a psychometric standpoint. And then lastly, it would be great. It's great to have a measure, but we wanted to make sure that we could actually train clinicians to use the measure reliably. So that was the third step. So I'll go through these steps in sequence. So the first step was really to try to address this feasibility issue. As I mentioned, we have 150 behavioral codes on the full measure. We write these long, detailed narratives about how you go through and what the mom's doing and how she's responding. And it's a page or two for each dyad. The training to learn the measure is 3 days long, and then you go and train on 20 additional tapes. Then you have to do 20 reliability tapes. It's probably 80 to 100 hours. And the other feasibility issue is that it wasn't coded in real time. So when video recording is not something that's accessible to many, it means you can't then code it. So we wanted to develop a measure that you could actually code in real time without the need for videotape. So I guess our big question was, how do we bridge the research to practice gap for the ambiance measure? So could we create a brief measure that maintains its psychometric properties? So I'm happy to say that we figured out a way to do that. And I worked with a good colleague, J.D. Haltigan, who actually was the sort of mastermind behind the analyses for this, where he really was able to take those 150 behavioral codes and shrink them down to 45, which is far more manageable than 150. And what he did is these are examples of all the different codes that you might see under the dimension of role boundary confusion. So you can see there are lots here. And what he did was really focus in on statistically on the items that were going to be most important for capturing disrupted caregiving behavior, and the ones that best distinguished disrupted or not disrupted caregiving. So he was able to then take what is 150 behavioral codes and turn them into 45 items. So that basically reduced it by 3 times less coding in terms of the items. So that was a small step forward, and was also able to demonstrate that even this reduced set of 45 items was still predictive of disorganized attachment. We then took those 45 items and went to some clinicians and said, what do you think? Because it's great that we can get that statistically, but it has to make sense in practice. So we were able to try to kind of connect the research to practice by going and getting some clinical consultations with our partners that were part of this project and say, do these items, 45 items, make sense? Are these the ones you're seeing in child welfare settings, in clinical settings? And so we did a little bit of refinement based on clinical consultation with our partners. We then took that brief measure and wanted to assess the validity of the ambiance brief in a completely separate sample. So we did this in the paper published here that was led by one of my graduate students for her master's thesis. And what we did was we coded about 75, a sample of 75 adolescent mothers that we had their videotapes for. They engaged in a parent-child interaction, and we coded it on the ambiance full, and then a separate set of coders coded the ambiance brief measure. And what we wanted to see was, are those two measures predicting similar things, and are they associated? Because that would tell us there's some validity to the long measure and the brief measure. So we also took time. So we wanted to say, although we tried to create a scenario as similar as possible to real time, we said to the coders who were doing the brief, you can't pause it, you can't rewind it, you have to just code it as though it's real time. And then they wrote down how much it took them to code a 3-minute interaction. So for each 3 minutes of interaction, it took 6 minutes to do the coding. And that's because they wrote notes and thought about what their score was. And this is about a 90% reduction in the coding time. So that we thought was really encouraging, because it meant that we could use this in real world practice. And then we also found good convergent validity. So that just means that the ambiance brief was picking up on a lot of what was in the ambiance full. So we were actually getting good, when we're coding the brief measure, we're getting pretty good precision in terms of what we would have coded if we had coded the long measure. And so that's encouraging. And then we also found that it was associated with disorganized attachment. So the brief measure, even though it's brief and it's quick and it was only taking us 6 minutes, was still predicting disorganized attachment, which is important. So the findings from this was that, the ambiance brief demonstrates some initial feasibility, because we could code it in real time. Coders were reliable in what they were seeing. There was some convergent validity with the full ambiance, and then it was predictive of disorganized attachment. And so the last step was really to examine the step 3 is, well, can we have a measure, but can we then train clinicians to use the measure in a brief training and to use it reliably? And the summary of this part of the project and the feasibility of training providers is found here. So what we did is a 2-day ambiance brief training. So we went, this is pre-pandemic, we went into different child welfare organizations who were partnering with us for this project. And we did a 2-day training at the time. And at the end of the 2-day training, they then coded 8 videotapes in real time. And we then compared their coding to those who were coded in the research world, who had a lot of experience with the ambiance measure, to see how reliable are people who coded after just 2 days of training, coded 8 tapes, with those people who are really trained in the measure. So that was really the project. There were 46 child service providers who did this project with us and engaged in the training. Very few of them had any experience with any observational coding paradigms. And when we asked them on average, how comfortable are you feeling doing observational coding of parenting? They gave scores about 3 out of 10. So many of them were really not actually comfortable learning observational paradigms, but that actually didn't deter them from engaging in the training or the reliability results, which I'll say, like a spoiler alert, came out really well. So the training entailed, this is just a sample schedule, but lots and lots of review of videos. So not a lot of theory and an overview of the measure, but just watching a lot of videos, talking about them together, giving examples of these 45 items that are on this measure, and just doing lots of group practice. So training, talking about it. And the majority of our discussion was really, we'd watch a video, we'd talk about what people were concerned about. What are you seeing that you're concerned about in this dyadic interaction? What dimension stood out to you as being most problematic or that you're concerned about? And was there anything you noticed that wasn't captured in the ambiance brief measure that you think is important? And then we're always sure to talk about the strengths as well, because this model focuses on some of the things that aren't going well, but it's really important to talk about what is going well, because that can actually calibrate your score when you go in and score these videotapes in terms of the level of disruptive communication. So we ask about strengths, what would you tell moms to do better? So another way of saying this is imagine you're working with this family. What are the things that are jumping out at you? What are you concerned about? What's the front page news story? If you were doing an intervention, what's the first thing you would focus on with this family? And what strengths does this caregiver bring to the table? Or what would you say to the parent? Keep doing this. This is fantastic. So we just do lots and lots of discussion around that. So amongst these 46 individuals and child service workers who had never had any exposure to the ambiance, 89% of them actually became reliable in the use of the ambiance brief. So this was just a really pleasant outcome because it tells us that individuals can get trained and reliable in the use of this measure. So that was fantastic. And even though a lot of people had some discomfort in learning observational paradigms and coding of parenting behavior, they all did so well when it came to, testing their reliability in terms of how well their scores compared to expert raters who've had tons and tons and tons of experience doing all this coding. One of the nice things to come out of some anonymous surveys that we asked them to fill out after the training is 100% of them said they would recommend the training to their colleagues, and 86% said that they would use this measure. They thought it would be very useful for their clinical practice. So in the end, this project that we did, the Ambiance Brief project, shows us that it is a measure that can be used. We have feasibility for training on it, and we think it is a measure that can be really well used in clinical practice, especially when if you're screening and trying to decide, does this caregiver and child need a dyadic intervention? Do they need a relational intervention? And then how well are they doing in treatment? So it's something you could code over the course of treatment just to see if there are any improvements. In terms of next steps, so what have we done since? Well, this pandemic happened, so that made things we had to get a little bit creative. But when some of the news came out that, or not the news, but some of these studies came out about this brief, we had a lot of interest in people really pleasantly from around the world saying that they'd like some training in the Ambiance brief. And so what we did, like many others, is move rapidly to an online training format. So we've now done about I think 4 or 5 trainings online over the course of the pandemic to about 100 different clinicians and researchers around the world, which has been great. And I'm really delighted to say that that reliability rate has kept up, and it's even gotten better. So we've had about 97% of those who are taking the training become reliable in the use of this measure. The next step we're doing from a research standpoint is to validate the brief measure in a low risk sample. So in a sample with, there aren't a lot of risks necessarily, but we still know there's some disorganized attachment. So we're looking to see if this measure can be used in a sample that doesn't have a lot of risks, and that has implications for research, but also any practitioners who might be working with families who just want to work on relational repair, and there isn't a particular concern from a child maltreatment standpoint about the dyad. We also have been asked to do some clinical consultation as people have learned the measure and then want to follow up and get some hands-on experience in terms of our working with the Ambiance and integrating it into their practice. And then we've been translating it into other languages, so currently translating it into Dutch. And then I have the pleasure of working with Chantal Sia, who's also working on translating it as well into French. So if you want to learn about the brief a little bit more, you're welcome to visit my lab's website, and we try to kind of give an overview of the brief, and if there are any trainings, we do put notifications there. And I would be remiss if I didn't actually point out some really wonderful research going on by other colleagues of mine who are working to try to translate some of the work in attachment or some of the attachment measures into more translatable into clinical practice. So I've put these up here so that you can refer to their work. So Pascal Fearon's been created a short measure to examine infant attachment. I know George and his colleagues have worked on a shorter measure of maternal sensitivity called the mini MBQS. And also other colleagues have tried to do something similar in getting students and clinicians trained in using various videos to code intrusiveness and sensitivity, caregiver intrusiveness and sensitivity. So I wanted to end with just a discussion about how we then go and apply some of this work, so some clinical applications of this tool, of this Ambiance measure. So as I mentioned, one of the suggestions is to use the measure to determine if the family actually needs a relational intervention. So you could use it as a screening measure to say, is the dyad struggling? Is there a lot of disruptive caregiving behavior? If so, then you might want to channel the families towards an intervention that's going to augment the parent-child interaction, those serve and return interactions, but also reduce the risk of some of these disruptive caregiving behaviors. But it can also be used in conjunction with other assessments. For example, if you're doing an assessment looking at, the family dyad and how they might be doing in terms of their caregiving behavior, it can be one tool in a tool set of tools that you might use to make that assessment. It's not meant to be diagnostic, so it's not a diagnostic tool, and not really meant for parenting capacity assessments unless it's being used in conjunction with a variety of other measures. So I'll go through a case example, and one I've been fortunate to work with my colleague, Catherine Borland-Kerr, who's at Guelph, the family service, one of the family service agencies there. So, and all these names have been changed, but you can see here that there was a mom and she had an 18-month-old son. And at the time of her involvement with this child protective service, her parents the child had been out of her care for about 9 months, but mom was really eager to get the child back into her care. She had, an extensive history where there was a lot of unsafe caregivers that had been around the family. There was some substance misuse. The child was unfortunately exposed to some domestic violence, and there was some indication that he'd also experienced some neglect. So the child was removed from care, and mom and the child had been doing supervision visits for a number of months. So when the agency first observed how the mom was interacting with the child and did an observational assessment, they found that mom was doing a lot of whispery voices. So, speaking like this really quietly, or not really using like an adult voice to indicate that she was present in there, but seemed more apprehension in some of her voice quality. She was crouching behind Gregory while he played. So rather than getting in front of him, she was sitting behind him and crouching down on her sort of hands and knees, and not making her sort of body language available to the infant. She tended to follow him during the play, sort of hovering over him, and being around, but not really engaging with him and having a lot of those serve and return interactions. When she did pick him up, she wouldn't pick him up in a way where they would be able to have some eye gaze or warmth and interaction. Rather, she would pick him up and turn him around and away from her body. So that would be something we think of as a withdrawal behavior. When Gregory became upset, she didn't know how to comfort him. So she wasn't really able to provide comfort to him when he was under distress, but it was observed that he could be comforted by the stranger. So there was capacity in Gregory to be comforted, and really the mom needed some help in terms of figuring out how they were going to make that work together. There would be the really long diaper changes. So they take about 10 minutes. And you can imagine when a young child is as you almost probably all know, when a diaper change takes 10 minutes, that's really long for a child. They get restless, they get frustrated, they move around a lot. And we just noticed that the mom would get really lost in the process. So she'd daze off, she'd get distracted, sort of wouldn't get the job done of just getting the diaper change. And that actually just created a lot of distress for the dyad. And then she'd also do some body freezing. So she would sort of still and freeze in the process, and zone out, essentially. So when the observation was done and the child behaviors were noted, what was the workers on this team were noticing that there was a lot of avoidance of eye contact. So the child was not looking to the mom, was not checking in with the mom, wasn't making any references to the mom for what to do or how to behave. There was a lot of interest in play. So the child was really, eager to be part of learn about the toys and play with the toys. They noticed this dance happening. So mom would move close, child would move away. Child would move close, mom would move away. So they never kind of came together. They were in what we often call this awkward dance, where it's not synchronous in any way. The child really didn't talk a whole lot. So there were very limited vocalizations, and the mom wasn't talking much either. So there's just not a lot of dialogue during the interaction. And again, no referencing or checking in with mom when someone would come into the room. So the child was crying at the beginning. So crying when left with mom at the start. So when the child and mom had to be together, initially at that initial reunion after the child's, he's been with a foster caregiver, there's a lot of tears, and mom just wasn't able to console him. It seems like the workers were able to comfort him. So when the workers would come in, the child seemed to be able to be comforted by them. But then he would cry again when the workers left the room. So there were some area of strengths, which is really important to note. So, you know, Tanya really wanted to be there. She wanted to play. She really took delight in what he was doing. So when he was playing with the toys and the child was very focused on the toys, rather than focused on the mom, focused on the toys, but she delighted in that. So when there were non-distress interactions, the dyad operated a little bit better. So mom could comment on what he was playing with, or, you know, she wanted to be around and engaged. So she really did want to be there and want to be a better or a more supportive parent to this child. But she said that she just wasn't sure how to do that. So a lot of the focus for this part of their observation or supervision visits was to support her in doing this, because she was really eager to actually have these this connection with this child. And she also said that she really wanted to provide the child with hugs and affection. She wanted to actually have those warm interchanges that we see between parents and caregivers sometimes. But when she got close, you know, it wasn't, she would sit close, but the hugs may not always happen, or the eye contact maybe didn't always happen. So that was something that we noted as a strength, that there was a desire for hugs and affection and contact, but maybe less knowledge and understanding of how to make that happen. So the sort of treatment plan was to identify areas of concern, and I'm just giving some examples here, to work with the client around how to take steps towards change, and then how the child welfare staff could actually, child protective service workers could actually support her. So getting some buy-in from mom around how this could work and what she wants to do and what might help her in this, make these changes in her behavior. So sometimes Tanya's voice becomes nervous sounding or more like a child. When this happens, Gregory will not see his mom as the one in the room that is supposed to keep him safe and protect him. He may think she is nervous and not sure she can take care of him. This could confuse or scare him. So this is basically describing some elements of disorganized attachment, but in language that the mom can understand, and that everyone who's part of this case file can also understand and work with. So the steps towards change were that it was that Tanya would be more aware of this and work to keep her voice confident but kind. And Tanya said that she wanted the staff to remind her when they heard those voices. So she said, I need you to prompt me when I do those voices, because I'm not always aware that I'm doing it and I'd like to make the change. So that was sort of the plan that they came up with as a team. The other example that they noted was that sometimes when the mom picks up the Gregory, she holds him away from her body rather than close in terms of warmth. So this may make Gregory think she doesn't want to be close to him, or that the mom isn't sure she can like confidently take care of him. And that's essentially explaining a withdrawal behavior and trying to put it in language that that everyone can get on board with. So Tanya, the team and Tanya decided that she will make sure when she holds him close and lifts him in. We'll find ways, if there are any challenges or barriers, we'll find ways to help her with that, because she wants her son to feel safe and secure when she picks him up. And just as important it is to pick them up and hold them close, it's also important to recognize when they need to get down. So kids often have what I call a wiggle indicator. So they will sort of nudge around and move around when they get down. We don't want parents to restrain them just because they themselves want that close contact. So it's equally important to teach and work with parents around recognizing cues that it's time for the child to get down and get back into play. So Tanya said that she'd like reminders if she holds Gregory out and away. So please prompt me, please remind me. She'd like to ideas to create closeness together and connection, even if he doesn't want to be held. So how can she create closeness and connection even at times when he doesn't want to be held? So when this treatment plan was developed, and this is just a little piece of it, it was longer than this, but just giving some examples, Tanya said, I don't think this is not going to make a difference. I'll do this, but there was not a lot of buy-in in terms of how much she thought, how much change this would create. But they proceeded with the treatment plan anyway. What the staff said around it is that it really gave this agreed upon plan. So the whole team had a template for what they were working on, how they could do support and coaching, and how they could make that consistent around all staff who are working with this mom. Really, fortunately, after about 10 weeks of these types of visits and this work with this mom, in an observation, there was no more crouching behind her son. Her voice tone was becoming increasingly confident. The diaper changes became fast and efficient because she really worked at making those quick and getting back to play. They noticed, because there was a lot of promotion of verbal and these serve and return interactions, that the child was becoming more verbal in front of mom, more eye contact, and was really more looking at her more consistently when he played. So he was looking to mom and doing that referencing to mom, which is great. And I suppose one thing that's, it sounds negative because he hid behind his mom's leg when a stranger came into the room, but that's actually a really good sign. So he used his mom as someone he could go to and sort of protect himself when a stranger came into the room. So rather than go to the stranger and try to get help from them, he was actually able to use mom as a secure base. So that was a really good sign after 10 weeks of working together. So and then lastly, just like when Gregory approached Tanya, like he took her hand, he pulled her to what he wanted, and they actually started to become really synchronous in their interactions. So Tanya's feedback at the end of this treatment plan session was like, all the tips really helped me see what wasn't working. I didn't notice on my own. It was surprising what a big differences changes like that could make. So I think that's an important statement because, she really didn't think it would make a change. And then one of the service workers was just, who was working on the project, family service workers said, with Tanya, I knew what I was seeing was concerning, but I didn't know how to name and identify it. The ambiance helped me to explain to my client what I was worried about and had a big impact on the way I do this work. So that was just some positive feedback that we received from the staff around, how the ambiance brief helps them have a common language together and helps them come up with a collective work plan or clinical plan for the various families that they work with as part of their child protective work. So I think that that's about all I have today. So I think there's time for questions. I want to thank all of you for coming and listening and learning a little bit more about this, and also thank George and his colleagues for inviting me to come and take part in this really wonderful series that they have organized for all of you. And then I want to thank everyone in my labs. So I have, the great pleasure of coming and getting to talk about the research that we do, but none of it happens in isolation. And there's everyone that is in my lab here, graduate students and research assistants, postdocs, and undergraduate students who we really work hard collectively and work towards some of these making these projects a reality. So I'm very indebted to them. And I'm looking forward to taking your questions.